All right, so for today's video, we have another cardiology collaboration, and we're going to be talking about a common cardiac complication of surgery in atrial fibrillation.
All right, so we're going to go ahead and jump right in. So, to sort of outline today's talk, we're going to talk about what atrial fibrillation is in general, some common postoperative causes of atrial fibrillation, the fundamentals and general principles of working it up and managing it, and sort of ultimately our goals of treatment. So, from a surgeon's perspective, why do you care about atrial fibrillation?
Yeah, I think AFib is a really important topic for us to talk about because it's actually rather common depending on the type of surgery, particularly thoracic, cardiac, or vascular surgery. There are actually quite high rates of AFib, but even with any postoperative patient, especially as our patients get more and more elderly, it's a complication we're all going to see and should be comfortable initially working up. And that's especially important because this is often not just a cardiac problem, but a problem that is a harbinger of some other postoperative complications that we need to be able to manage ourselves as surgeons.
Yeah, exactly. I think that's a great way to introduce what it is and what atrial fibrillation is in general. So, as you guys remember and know well, so in terms of the normal pumping chamber of the heart, the atria, or the top chambers of the heart, pump, fill the ventricles, and then the ventricles sequentially pump blood either to the lungs or the systemic circulation. In atrial fibrillation, which is the most common heart arrhythmia, affecting up to 1 in 100 of the population. The atria or top chambers of the heart beat or quiver or shake or fibrillate abnormally, usually at a rate of about 400 to 600 beats per minute. And in terms of the pathophysiology, I want you to think of really anything that causes increasing pressure in the left atrium, sort of dilates the left atrium and can predispose patients to getting atrial fibrillation. So the most common thing we see are age and then a stiff or thick heart. So left ventricular hypertrophy, which can be related to obesity, high blood pressure, sleep apnea, among other things. And then generally in the postoperative state, we see some degree of high circulating catecholamines. And these sort of factors play together in the development of postoperative AFib. So this is a pretty simple, straightforward ECG in terms of a patient who would be coming in with atrial fibrillation with RVR, or someone you would see postoperatively. The key factors that I always want you to remember, obviously, the rate is tachycardic. That's one key. You don't see any clear P waves. What you're seeing here periodically, these are just fibrillatory waves. You can see that the R waves, here to here, for example, versus here to here, is completely irregular. The sort of pathognomonic finding in atrial fibrillation is an irregularly irregular rhythm, and that's what we see here. So if you see someone, no clear P waves, irregularly irregular, and tachycardic, those are the defining features for atrial fibrillation. So in terms of potential causes, in a postoperative patient, I want you to think of a high catecholamine surge being the cause of atrial fibrillation until proven otherwise. And in a postoperative patient, that can be anything from infection, that can be wound infection, intra-abdominal infection, pneumonia, etc., bleeding, particularly from the surgical site or related to the surgical site, hypoxia and hypercarbia, that could either be from something like a new PE, or if they have sleep apnea and they haven't been on their CPAP, or they're still waking up from anesthesia, and are still sedated, for example. Volume status in general, so that can be either hypovolemia, related to under resuscitation, or fluid overload if they're a patient that has long-standing heart failure, they got too much volume in surgery. Electrolyte abnormalities, particularly hypokalemia and hypomagnesemia, are the important ones to know. And then I'll add in here as a caveat thyroid disease. Usually people know about underlying hyperthyroidism, but it's something important to check. And then Substance withdrawal is always something important to think about. We always hope our patients tell the truth, but alcohol withdrawal frequently. So if you see someone who has a history of drinking and is presenting with AFib with RVR, usually post-op day 2 or so, this is another important thing to think about. And then in terms of underlying heart disease, can you think of some underlying heart conditions that could predispose someone to having atrial fibrillation?
Sure. I think, like you're saying, it's interesting that we've talked about all these potential causes for AFib and we haven't talked about underlying heart disease yet. And I think that really brings home the point that if the only thing that's changed in a patient's status is that they've had surgery, whereas previously they hadn't, and now they have a new onset of AFib, that probably there's something going on related to the surgery that we as surgeons need to be really acutely working up and managing. When it comes to heart disease, just about any heart disease can predispose you to AFib, is my understanding. Like you said, it's the most common arrhythmia. Some things that we can do wrong that would lead to AFib would be things like withholding medications. Generally, patients should be on their beta blocker in the peri-op period, but if it's held, maybe for some hypotension, that could be an issue. Or if they have CHF or valvular abnormalities.
Yeah, perfect. I think you hit pretty much all of them. So, and the other point that he made that I want to reemphasize, and if there's one thing you get and keep from this talk, it's that most likely it's not something new from the heart. It's usually someone who has the risk factors we talk about, may or may not have pre-existing heart disease, and that can be valve disease, heart failure, or known history of AFib previously. But it's usually some sort of stressor in the new postoperative period that is contributing to their atrial fibrillation with RVR. I also want to mention and point out, I frequently get asked the question, is it possible that they're having a myocardial infarction or heart attack? It is possible, but rarely we see, very, very rarely we see atrial fibrillation as the only presentation of an MI. It's usually accompanied by symptoms and other EKG changes besides just atrial fibrillation. So this will be a common page for any of you who are working as sub-interns or as interns in probably the upcoming couple of years. So if you were to get this page about a patient, Mr. Smith, he's post-operative day 1, and his heart rate is 145. Please assess. Kind of talk me through what your thinking is and what your plan is after you get this page.
Yeah, so I see this page, and I'm assuming that this is an acute finding. That's why they're paging me about it. So I'm fairly concerned anytime I get a page where there are significant vital sign abnormalities that gets top priority. So I'm going to be calling this nurse back as soon as possible and asking her a little bit about the patient. And while I'm talking to them on the phone, I'll be putting in some orders for some key studies.
Okay.
So usually what I'm going to ask them right away is, are there any other vital signs, abnormalities, most concerning, or I'm most concerned about hypotension with this tachycardia or altered mental status. I just want to kind of get a picture of what's going on quick while I'm ordering, for example, my EKG and likely some labs, and then I'm going to be going to see that patient as soon as possible.
Great, perfect. So I think you totally hit it on the head. I think and the first thing you should think about in this patient are the rest of their vital signs. You notice in the page they only gave you the heart rate, but definitely want to know what their blood pressure is and what their respiratory rate and O2 sat, etc. When you're kind of on your way over there, you may have ordered some of the things that you mentioned, including an EKG and some labs that we'll talk about, and then talking to the patient and getting a sense of if they have any symptoms, and doing a physical exam will be important when you get to the room as well. What sort of labs are you thinking about ordering on these patients?
Yeah, so like you talked about when you were talking about the causes of a catecholamine surge, I'm trying to rule out most of those things. So I'm getting a pretty broad lab panel, certainly a CBC, which would talk to me about infection or anemia. I'm thinking about getting a BMP plus a magnesium to look for any critical electrolyte abnormalities. An MI is rare, but we certainly don't want to miss it. So I'm going to get a troponin and be trending those. Um, and then in the acute setting, I'm not as worried about it. But like you said, you can work up thyroid studies, a couple of those rarer labs. Oh, and depending on what the nurse is telling me on the phone, I might add on a blood gas and a lactate.
Perfect. I think you hit most of the big ones that we want to think about. And then some other studies you may think about are imaging studies, and that's mostly related to after you've seen the patient and examined them. If you're concerned about some of the other causes we talked about, for example, if someone has just had an abdominal surgery and you're, concerned that they're hypotensive or their drain output is picked up and looks bloody, if you're thinking about getting a CT to assess the abdomen, or if they're hypoxic newly and you're concerned about a PE, there's not specific imaging studies that you order in the acute setting, but that's sort of patient and case dependent. And then you may get a cardiology consult in some of these cases. Generally, we'll talk about that a little bit later in terms of when would be appropriate to get cardiology involved versus sort of initial management. So, in terms of management of the patient, so we'd ordered an EKG and some lab tests, and you'd sort of alluded to asking about the rest of the vital signs. What other things are going on in your head about the patient when you're walking over to assess them in person?
Yeah, so the first thing, kind of the most versatile and quick tool that you have is just talking to and looking at the patient. So I'm going to be taking my history from them. And the first thing is, can I take a history from them or not? If they're altered newly, that's a huge concern, obviously, about their cerebral perfusion. But if I am able to talk to them, that reassures me a little bit that whatever they're doing right now is at least able to perfuse their brain and keep alive their basic bodily functions. Once I'm talking to them, I'm also going to be looking at the monitor, looking at the blood pressure, and really deciding is this stable or unstable AFib, because that's going to change my very acute management in that moment, regardless of the underlying cause.
Perfect, exactly. So when you're talking to a patient, exactly the first time you see any patient with any sort of tachyarrhythmia, particularly AFib, stable versus unstable is always the first thing you should think about. If they're unstable, you go down the ACLS pathway, which we'll talk about briefly. If they're stable, you want to do a sort of limited focused history and physical. You want to really ask if they're having symptoms, and the symptoms you're most concerned about are chest pain, shortness of breath, are some of the most common, lightheadedness or dizziness, and then altered mental status, like you mentioned. And that, they're not going to describe if they're altered, but asking key history and orientation questions will help you get a sense of how their mental status is doing. And then on physical exam, you want to auscultate for abnormal rhythm and rate, which you'll get a sense of. Ideally, these patients should be put on telemetry as well, which will also give you a sense of what their rhythm is. And then trying to get a sense of their volume status will be helpful. So, listening to their lung fields to see if you hear crackles, if you can assess their jugular venous pressure in their neck, and for evidence of lower extremity edema or swelling. Those will be key findings that can suggest someone has evidence of extra volume on board versus someone who is sort of warm, vasodilated, bounding pulses, etc. That may be someone who's infected. So there are certain very key physical findings that will be helpful in elucidating the causes of what may be going on in this patient. So, in general, our goals of treating these patients, like you mentioned, first stabilizing the patient. So, if they're unstable, going down the more of the ACLS pathway to make sure they're stable, and then figuring out the underlying cause. And like I said, I can't stress this enough because you can throw medications at them all you want, to try to get their heart rate down or try to get them out of atrial fibrillation. But at the end of the day, if you haven't corrected the underlying cause, they will still be constantly predisposed to going back into atrial fibrillation. Once you've identified an underlying cause and are working to address that, you can also think about rate controlling them and liberally rate controlling them, not sort of trying to drive their heart rate down as low as possible. So, in terms of managing patients, in terms of an unstable patient, what would be the first thing you do for an unstable patient with AFib with RVR?
I was really hoping you wouldn't ask me the ACLS algorithm, but it looks like here we are. So the first thing that you're thinking with unstable AFib is about electricity. So getting the pads available, getting them on the patient, and then I'm thinking about cardioverting if I'm unable to get them stabilized otherwise.
Yeah, exactly. So in an unstable patient, and we always think of patients who are hypotensive and are showing signs of hypoperfusion and altered mental status and inappropriately low urine output are sort of the really quick bedside markers you can use for assessment. I'm thinking about using electricity or performing a direct current cardioversion on these patients, exactly like you said. And then what about in a more stable patient? What medications are you thinking about using?
Yeah, so in a stable patient, I really see myself as having three choices, really two big ones at the beginning. If their blood pressure is very clearly will tolerate it, usually I'm first trying beta blockers, usually metoprolol. If their pressure is a little bit on the lower side, I might be thinking of something more like amiodarone. And then the third option is the centrally acting calcium channel blockers, most typically diltiazem.
Great, exactly. So I would say your first line medication is exactly right. Metoprolol, uh, in terms of IV beta blockade, that'll give you the biggest bang for your buck. It generally doesn't affect your blood pressure a whole lot. Usually we give it in stacked doses. So we give 5 milligrams 5 minutes apart for up to 3 doses. And this may be a little bit different depending on your institution, but this is generally recommended as your first line. In terms of centrally acting calcium channel blockers, diltiazem is used a little bit more frequently than verapamil. Diltiazem is generally less potent in terms of causing low blood pressure, and you can use it as a continuous infusion, which makes it a nice choice to transition to if a patient can't take pills, for example. And then amiodarone, as you mentioned, in people who have underlying heart failure or really low blood pressure, and you don't think you can get away with using a beta blocker or calcium channel blocker, is always a good option. I want to just mention digoxin because you may have heard of it being used for atrial fibrillation rate control. Digoxin generally tends not to work as well in high sympathetic tones or high catecholaminergic excess. So digoxin is less commonly used in the postoperative setting. And then, as we mentioned before, cardioversion in someone who's truly unstable and you're thinking about ACLS.
You mentioned something about different meds being good or not good for people with heart failure. Can you expand on that a little bit? How do you decide who's in heart failure and which meds are good or bad?
Yeah, exactly. So generally, if someone's had a prior echo within the past 6 months or so, I generally look at that ejection fraction. Usually, if their ejection fraction is above 50% or so on that echo, I would say you're safe to use essentially all of these medications. If their ejection fraction is less than 50%, I would avoid calcium channel blockers. These have a really potent negative inotropic and chronotropic response, and they can cause really profound hypotension in someone with a reduced ejection fraction. And we didn't mention this, usually in the acute setting, like we talked about, you want to stabilize the patient and then kind of work on figuring out why they're in AFib and then use medications. Usually, sometime during their hospital stay, like I mentioned, if they haven't had an echo in the past 6 months or so, you're usually not urgently getting an echo to assess what their LV function is and left atrial chamber size, et cetera, to just have that as a baseline.
Yeah, so a lot of details on this slide. Don't feel like you need to know all of them, especially if you're a medical student, but hopefully it's good for you if you're curious, if you want to know a little bit more, but really just focus on are they stable or not? If they're unstable, what do I do? If they're stable, what are my big classes of meds? And you'll be able to follow along in the hospital a lot better.
And then just a quick point about longer term management. Something that everyone should know about is patients who have any history of atrial fibrillation are at increased risk of stroke. And even that can be even people who have sort of self limited shorter term episodes of AFib. So this is not necessarily something that you have to think about right in the acute setting, but something that should be thought about closer to discharge in patients. is anticoagulation. And I won't go into it too much, but it's helpful to be familiar with two scores. You may hear them, you don't need to memorize them, but you'll look really smart if someone's talking about bleeding risk, or should we put this patient on anticoagulation. There's two major scores. The CHADS VAS score helps us sort of risk stratify patients in terms of what their estimated annual stroke risk is, with certain risk factors for the development of AFib. And then the HAS-BLOOD score is their bleeding risk. And we usually take these scores into account when we're deciding when to put someone on long-term anticoagulation. Again, it's not important that you memorize this. It's just good to know because these are referenced quite frequently, and this is what we use to help us determine the safety of anticoagulation, obviously in conjunction with talking to the patient and their family. So that's all I have. I hope you learned a little bit about atrial fibrillation in terms of the basics and management, and are a little bit more familiar with it the next time you will inevitably see a patient with postoperative atrial fibrillation in the hospital.
Awesome. Thank you so much. As always, I've learned something. I'm sure people watching will learn something as well. It's a big topic. We just scratched the surface here. Um, so if you have follow-up questions, we're always happy to answer those in the comments or maybe with future videos. We hope you enjoy. Remember, this video is for educational purposes only. Do not use this to diagnose or treat any diseases, and we'll see you next time.